Cast is now starting. All attendees are in listen-only mode.
Okay, good afternoon and welcome to the Population Health Research Network webinar Wednesday, kindly hosted by the ARDC. For the next 4 weeks, we're going to have a Wednesday webinar at about lunchtime, Eastern Standard Times, and we hope to bring to you a researcher who has used our PHRN network to assist with data linkage and their specific research. This week, I'd like to introduce to you Dr. Chris Davies, who is a senior biostatistician with the Australian and New Zealand Dialysis Transplant Registry. And Chris will talk about how researchers use data linkage to his registry to investigate renal replacement therapy treatments and outcomes of patients from other cohorts. There will be the opportunity to ask questions. You will be able to ask questions through the chat question box on the screen, and we will deal with the questions at the end. I will now pass you over to Chris.
Thanks, Nicola. Are you able to share? Thank you.
Thank you, presenter.
Yeah. Hopefully that looks okay.
All good.
So thanks, Nicola. As said, I'm Chris Davies, and today in this webinar I'll be talking about data linkage to the Australian and New Zealand Dialysis and Transplant Registry, or ANZDATA, whereas I'm a senior biostatistician. I'll start with a description of the registry and then cover a variety of the linkage projects which have involved the registry's data. Sorry, I'm just getting a message that's come up. I don't really understand why. All right. So ANZDATA is a clinical quality registry, of which there are a number in Australia. These organisations monitor the quality of healthcare within specific clinical areas by routinely collecting, analysing and reporting health-related data. CQRs then use this data they collect to identify benchmarks and variation in clinical outcomes, and feed this information back to clinicians to inform clinical practice and decision-making. This is a figure from the Australian Commission on Safety and Quality in Healthcare, which represents the continuous feedback loop that CQRs provide to improve healthcare. This improvement comes through the improved patient outcomes, along with increased compliance with evidence-based guidelines and standards. The data that registries provide can also be used to inform the development of new guidelines and standards. The Australian New Zealand Dialysis and Transplant Registry, or ANZDATA, collects and produces a wide range of statistics related to the outcomes and treatment of those with end-stage kidney disease, which is where kidney disease has progressed to the point where dialysis or kidney transplant is required for survival. These treatments are also known as renal replacement therapy, or RRT. All renal units in Australia and New Zealand contribute data to ANZDATA. ANZDATA has been in operation since 1977. Following the merger of the previous dialysis and transplantation registries. This means we have data going back to around the first ever RRT in Australia in 1963 to today with over 85,000 patients in the registry. Researchers can use linkage to ANZDATA to investigate the RRT treatments and outcomes of patients from other cohorts, such as clinical trial cohorts or from observational cohort studies. And ANZDATA ourselves also conducts linkages to other datasets for validation, research, and to increase the scope of our reporting. Shortly, I'll describe some examples of each of these. Linkage to ANZDATA can be conducted in-house by ourselves or generally for larger projects through a data linkage organisation or through the Population Health Research Network. At the moment, ANZDATA is incorporated into the Master Linkage Keys of SANT DataLink, the Centre for Health Record Linkage, or CHERL, in New South Wales and the ACT, and in the Tasmanian Data Linkage here, though discussions are ongoing for other jurisdictions. In some cases, such as a small number of patients from one hospital, deterministic linkage is able to be used, as we have medical record numbers. However, often probabilistic matching is required. The only component of residential address that we collect is postcode, So commonly, name, date of birth, sex, and hospital identifiers are used for linkage. Data reported to our registry is not perfect, so in some cases, assumptions are needed about likely errors in the data entry. Here are the examples of data linkage to ANZDATA that I'll be covering today. First, a generic clinical trial cohort, which will have features in common with various linkages that we have conducted in-house for other researchers. Then, 4 linkages that ANZDATA have been involved with for our own research, validation, or to broaden the scope of our reporting. There's the linkage to the Joint Replacement Registry, a study of parenthood in patients receiving RRT, linkage to the National Death Index, and also our regular linkage with the National Organ Matching System, now known as Organ Match. This is the first example of a linkage to ANZDATA that I'll be describing. Often, small clinical trials will be conducted within a particular hospital or across only a few centres. In this case, those running the trial will have an identified list of patients that can be used for linkage to ANZDATA to gain more information about their cohort. If, for example, the trial is of chronic kidney disease patients, which is the earlier stages of kidney disease before end stage, the linkage could be used to tell whether the patient then went on to receive dialysis or a kidney transplant. Or, if the trial is of dialysis patients, linkage could be used to determine their latest treatment information. When the inclusion criteria of the trial overlap entirely with ANZDATA's, that is, all patients were on dialysis or had a kidney transplant, linkage to ANZDATA can then be used to provide long-term follow-up on patient and transplant survival. Linkage is often a more efficient and cost-effective option rather than going through the medical records of each hospital involved. My next example of linkage to ANZDATA is a project investigating joint replacement outcomes in dialysis and transplant patients. This project is possible through the linkage of ANZDATA to another national clinical quality registry, the Australian Orthopaedic Association National Joint Replacement Registry. The NJR includes Australian patients who have had joint replacement procedures such as knee, hip or shoulder replacements since 1999, including both primary procedures and revisions. They collect demographic and clinical information at the time of procedure. The clinical reason for this linkage is that patients with chronic kidney disease have bone problems such as osteonecrosis, osteoporosis and other causes of arthritis, as well as comorbidities, which are likely to increase the rate of joint replacement surgical complications. This linkage will allow us to estimate the rates of joint replacement procedures in dialysis and transplant patients, as well as to compare the survival and revision rates of the procedures to the general population. These analyses are only in their early stages, so I can't share any results with you today. The use of this linkage in this setting is particularly useful as these are rare events in a specific patient population. Compared to other study designs to answer the same questions, this will have no impact on patients at all and can be achieved with minimal cost. The next example of linkage to ANZDATA is a research project being led by Dr. September Dr Chris Davies of parenthood in patients receiving dialysis or kidney transplantation, which I've recently joined the analysis team for. This is a multi-jurisdictional linkage study of antenatal, obstetric and perinatal risks and outcomes. Through this linkage study, outcomes of those receiving RRT will be compared to the general population. Parenthood for patients on these therapies is uncommon but potentially high risk, and this study will estimate the rates of parenthood and also birth defects and other perinatal outcomes. Parenthood events are actually collected by ANZDATA, however there is known to be underreporting of these events, and the benefit of the linkage is to see the extent of this underreporting. This is the design of the parenthood study. Perinatal data collections include all births in each jurisdiction, but only include the names of the mothers. Therefore, linkage to ANZDATA can be done, a separate linkage avenue is needed for fathers via the births registry. The perinatal data is then linked to the other health data sets, including hospital admissions data, emergency department and neonatal intensive care, birth defects and death registries, as well as back to ANZDATA to receive the information about the dialysis or transplantation treatments of the parents. This allows the formation of 2 cohorts, the pregnancies from those who have been in ANZDATA and those who are not end-stage kidney disease patients. As this is occurring over multiple jurisdictions, many ethics approvals and other requirements have added to the complexity of this study. The study includes all births of more than 20 weeks or 400 grams, which are those reported to the perinatal data collections. between 1991 and 2013 in the Australian Capital Territory, New South Wales, South Australia and Western Australia. However, we only recently received the New South Wales data and we're waiting on the ACT data, so here is a flowchart for SA and WA combined. This diagram is also restricted to just mothers receiving RRT. There were over 1 million births in total to around 600,000 mothers. From the mothers who had ever been on RRT, there were 111 babies born after RRT was commenced. Most of these babies were born to mothers with a transplant. In the same time period in SA and WA, only 74 births were reported to ANZDATA, demonstrating the suspected underreporting. The remaining babies form the non-RRT mothers' babies cohort. From these two cohorts, we can calculate the crude birth rates, which are the number of births divided by the size of the population. Clearly, the crude birth rate is much higher for the non-RRT cohort, being 13.3 per thousand population compared to 2.1 per thousand. However, the age distribution of the RRT population is much older than the general population, and there are more males receiving RRT than females, so it's more appropriate to calculate age-specific fertility rates. These are the age-specific fertility rates for the SA cohort only. These are defined as the number of live births given by women in these specific age groups divided by the total number of females in that age group. As you can see, fertility rate peak for both cohorts between 25 and 34, but the overall fertility rate for RRT mothers is around 18 births per thousand women, aged 15 to 44, whereas for non-RRT mothers, it's over 3 times higher at around 60 births per thousand. Results were similar for WA. As I've shown, linkage of ANZDATA to the perinatal birth cohort datasets identified more births than those reported to ANZDATA directly, and allowed the birth rates and fertility rates for women receiving RRT to be estimated. These mothers and babies are now linked to extended perinatal and hospital data, which will enable us to explore pregnancy and perinatal outcomes and define maternal risk factors associated with adverse outcomes in this high-risk cohort. The findings of this study will assist health professionals in counselling and managing patients who are considering parenthood whilst receiving RRT therapy. As was mentioned as part of the parenthood study, linkage to a registry such as ANZDATA can be used for validation of our own data to assess differences in reporting. A linkage to the National Death Index, or NDI, that was conducted is another example of such validation. This linkage was originally established as part of the Celestial study led by Philip Mason. However, ANZDATA researchers led by Matthew Sypek used the linkage to compare the cause of death as reported to ANZDATA and that in the NDI. The NDI is a Commonwealth database that contains records of deaths registered in Australia since 1980, with data coming from the Register of Births, Deaths and Marriages in each jurisdiction, the National Coronial Information System, and the Australian Bureau of Statistics. Death is coded according to the International Classification of Diseases, or ICD codes, with ICD-9 being used until 1996 and ICD-10 since 1997. As well as recording underlying cause of death, the NDI allows for multiple other additional causes of death to be recorded. Causes of death for patients within ANZDATA is currently recorded using 84 different codes designed to cover the most common causes of death in this population, with the option of a free text other field also. This list was developed specifically for the registry and includes dialysis-specific causes of death, such as withdrawal from treatment. Also of note, in comparison with the NDI, it is not possible to record a cause of death as renal failure or end-stage kidney disease within the registry. Only a single cause of death can be documented for each patient. In this comparison study, data linkage was performed between ANZDATA and the NDI for all deaths in the period 1980 to 2013. Cause of death was classified according to the ICD-10 chapter. However, as patients can be reported to us with a cause of death under the category of withdrawal from treatment, the ANZDATA cause of death codes do not align perfectly with the ICD-10 chapters. The purpose of this work was to better understand how these coding systems differ, and therefore to aid in the accurate interpretation of output and to allow for meaningful comparisons of the data from the different sources. Overall and chapter-specific agreement were assessed using the CAP statistic, which is a measure of inter-rater reliability that takes into account the probability that the agreement occurred by chance. Descriptive analysis was used to explore the differences where there was disagreement on the primary cause of death. So these are the results from the NDI linkage. The analysis cohort included over 28,000 patients, and 95% of ANZDATA reported deaths fell within 3 days of the date recorded by the NDI. Overall agreement at ICD chapter level of primary cause was low, being 36% overall with a kappa of 0.22. Circulatory death was the most common cause of death in both databases at 48% in ANZDATA and 32% in the NDI. Agreement was best for cancer, listed here as neoplasms, with a kappa of 0.71. When there was disagreement on primary cause of death, these were most commonly coded as genitourinary and endocrine in the NDI, which were 35% and 25% respectively, and circulatory and withdrawal in ANZDATA for 39% and 24% respectively. The large difference in the endocrine category is because diabetes is also not a cause of death in ANZDATA. Diabetes is the leading cause of renal disease in ANZDATA patients, and a large majority of those with endocrine cause of death in the NDI had diabetes as their primary renal disease. 69% of patients had a renal-related cause documented as either their primary or a contributing cause of death in the NDI. In summary, in the study it was found that there was low agreement in primary cause of death between ANZDATA and the NDI. This is in part explained by the absence of diabetes and also renal failure as causes of death in ANZDATA and the absence of withdrawal in the NDI. These differences should be appreciated when interpreting epidemiological data on cause of death in the Australian end-stage kidney disease population. The last example I have of linkage to ANZDATA demonstrates how linkage can be used to increase the scope of our reporting. This linkage is to Organ Match, previously known as the National Organ Matching System, which matches donor organs to transplant recipients and manages the waiting list for these organs. Unlike the other linkages I've mentioned, which were set up as part of specific research projects, this linkage is through a memorandum of understanding we have to regularly receive this data. Having the waiting list data linked to ANZDATA allows us to publish these waiting list dynamics as part of our annual report. And in fact, we have a whole chapter of our annual report related to the waiting list that is only possible through this data linkage. These numbers relate to waitlisting for deceased donor or DD kidney-only transplants. Patients waitlisted for multi-organ transplants are excluded as they're allocated separately. Recipients of the living donor transplants may or may not be on the deceased donor waiting list prior to transplantation. The numbers of people moving on and off the waiting list for any reason are shown, and those taken off the list may return to the list in subsequent years. As you can see, the recent increase in the deceased donor numbers has mostly been matched by an increase in the number of patients being listed. However, the size of the list has come down a bit over the last few years. In our report, we also publish these dynamics by ethnicity, age, state, and blood group. As well as looking at the number of patients on the waitlist, the linkage also allows us to report the outcomes after waitlisting for patients made active on the list. This is for patients who commenced dialysis during 2012 to 2017 and were subsequently waitlisted for a kidney transplant. These analyses show the cumulative incidence of deceased donor transplantation, living donor transplantation, or death. Each outcome is considered a competing risk for the other outcomes, and only the first event is considered. Overall, patients were much more likely to undergo deceased donor transplantation than to receive a living donor transplant or to die. Above 40% received a deceased donor transplant within the first year, and around 80% received a transplant by 5 years. There were important differences between states, with longer times to deceased donor transplantation in the New South Wales, ACT and Victoria compared with the other states, and correspondingly higher rates of living donor transplantation, especially in the New South Wales and ACT. Note that these analyses only consider time from waitlisting. Differences in time from dialysis start to waitlisting may reduce some of these discrepancies. Here are the same data by blood group. Patients who were blood group AB or A received transplants more quickly than blood group B or O patients, since it is less likely that a donor is blood group compatible for B or O recipients. The linkage to Organ Match is also used for validation purposes, as we compare their records of who has joined the waitlist with our records of recent dialysis patients. Also, Organ Match's records of transplants are compared against our records to confirm what has been reported to us by the transplant hospitals. This linkage is also used for research projects that relate to the waiting list and organ allocation. In summary, data linkage to ANZDATA allows researchers to investigate the renal replacement therapy treatments and outcomes of patients from other cohorts. ANZDATA also conducts linkages to other datasets for validation and to increase the scope of our reporting. Thank you for listening. If you're interested in linkage to ANZDATA, please contact us up via our request email or through our website. If you'd like to follow ANZDATA, we're also on Facebook or Twitter.
Thank you, Chris, for that very informative presentation. I've been checking it. There haven't been any questions coming through, but I'll ask again if there's any questions you'd like to ask Dr. Chris Davies. There is a question box on the side of your screen which you can type and I can ask the question.
From the initial application for data linkage for, say, the replacement project or the pregnancy project, actually receiving the data?
Thanks, Stephen. I've just had a question from in the room here about the length of time from putting in applications to the time to receive the data. Don't know the exact number of years, but certainly it's a long time, and it was a long process for that pregnancy project. Shiva, do you want to put?
Yeah, I mean, we started working with the individual data linkage units some years ago, about sort of 4 or 5 years ago, and then the PHRN process came in and then we went through that. So it has taken a long time, largely because of the ethics requirements. We also need to go to Aboriginal ethics committees for the work that we do in the kidney space, mainly because Indigenous patients are overrepresented in the kidney cohort. So it has taken a long time, and then even after the approvals, there's obviously a queue for actually getting the linked data coming through as well.
Hopefully you could hear that, Nicola.
Yes, I did hear that. Yes, we do have our OAS system, which has now been up and running for several years now, which we are working on, hopefully speeding up the process and to link all those stages through. But yes, it is a lengthy time with the ethics approvals and the federation issues that come through. Now, are there any other questions? I haven't had any come through on the question box. Chris, do you have any others in your room?
Anybody else here?
Nicola, you actually have had some on the question box. I'm not sure that you're seeing them correctly.
All right, let's have a look. The only one
How about I ask them?
Yeah, because the only one I can see is that the sound has stopped working. Is the only one that I have got.
No, there's 4 or 5 after that. Okay, so Chris, I'll ask them for you.
Okay.
The first one that we have there is, can we request ICD codes from NDI data?
So my involvement in that project was limited, but I understand that if you were to have a linkage with the NDI, then we did get the NDI codes as part of that. But yeah, you'd have to go directly to the, I think it was the Australian Institute of Health and Welfare that we did that linkage with to confirm.
What was ICD coded?
Yeah. So when we received that, it was ICD coded.
I can just see, I can see some other questions, yes. How can we go about setting up a master linkage key with ANZDATA?
So I know we've done it with a number of the linkage organisations, but if you send the information of whoever is sending that through, you can send it through via a request email or via our website, and then we can get the conversations going about the establishment in your master linkage key.
Done that one. Yes, Susanna, I'm having problems seeing the next questions. They're very small on my screen.
Okay, yes, go-to doesn't make that any bigger. We've had a comment that says, wow, shopping kappa values. So I don't actually know what that means, but I'm sure that you guys know what that means. Then we had a request of the earlier one.
To that, Chris, is that they're actually different categorisation systems, so that while the kappa values are poor, they're not actually designed to measure the same thing.
Yeah, I think that's right, Stephen. Yes, and as I said, it was mainly due to the differences in the kind of the categories that are available under those systems that cause, I think, those kappas to be low.
And the best example is that about 30% of dialysis patients actually die following a withdrawal from dialysis, which we code as withdrawal from dialysis, but with the NDI coded separately, differently. There are many other examples.
Hopefully you hear that, Nicole's response.
Yep, I did hear that. Just going through to see I think it's the same questions. I think we've...
Yep, that's all the questions that I can see.
All the questions we can see. Yep, just going through. Yep. So I think that is all the questions. So thank you very much, Chris, for that very informative session. We will ensure that the audio and the visual is up on our YouTube channel, and I'll make sure that that's put up on our Twitter and our website. So then if you want to view the whole talk again, you can go to our YouTube channel. Next week we do have another webinar with Kate Miller, who's a PhD student from the Telethon Kids Institute, and she will be talking about her research. Is low sun exposure during early life a risk factor for type 1 diabetes? So you might want to look out for logging on and registering for that webinar for next Wednesday the 18th at the same time. And I've got one final plug for the PHRN. We have a symposium in November, and it's called the Australia's Data Future Symposium on the 21st of November at the Sydney Opera House. And if you'd like to book to attend, there are the details there. Thank you very, very much, Chris, for your time.
Chris, just
thanks, Nicola. Thanks,
has there been another question?
A last-minute question come in? Yes.
Yes.
It says, does ANZDATA have similar analysis like they did with the death index for comorbidities recorded in ANZDATA?
I'm not aware of a linkage that's been done to investigate comorbidities. I don't know quite what other registry of comorbidities would be used for that purpose, but yeah, that would be an interesting project, I agree.
Okay, thank you. I think, is that all the questions now, I think, that have come through?
I think that's all of them, yes.
Yes. Thank you so much, Chris. That was fantastic. And thank you for everyone for listening, and hopefully we'll see you next time.
Thank you.
Thank you.